Okay, so I think we're ready to get started here. So welcome everyone. Thanks for joining us today for the Provincial Human Services and Justice Coordinating Committee webinar. Today's topic is on innovations and alternative crisis response models. My name is Tasha Rennie and I'll be moderating the webinar today. I am the Network Engagement and Communications Officer with the HSJCC Secretariat. Before we get started, I wanted to go over a few housekeeping items about our presentation for today. So as an attendee, your camera and mic are automatically turned off. So if you have any questions or comments during the presentation, please feel free to type them into the chat box. And then we also have the Q&A feature, which we'll be using during the Q&A period at the end of the presentation. So you can use that to type any questions that you have for the presenters at the end of the presentation. And just one note about the chat box, if you would like to make a comment that's going to be visible to everyone, please direct your comment to all panelists and attendees in the chat. So just a note, our webinar is being recorded and a link to the recording as well as the PowerPoint presentation will be emailed to everybody after the webinar. We'll also be sending out a brief evaluation survey, so please feel free to fill that out and that will help us plan our webinars better in the future. And for anyone who's joining us for the first time today, the Human Services and Justice Coordinating Committee Network is made up of 39 local committees, 14 regional committees, and 1 provincial HSGCC. Each of these committees is a voluntary collaboration between health and social service organizations, community mental health and addictions organizations, and partners in the justice sector. And I'm very pleased to welcome our presenters for today. We're joined by Rachel Bromberg of the Reach Out Response Network and Susan Davis of the Gerstein Crisis Centre. So with that, I'll pass it over to our presenters.
Okay. I'm gonna share my screen if it works. Oh, look, it works. Amazing. If it loads. Okay. Hi, everyone. So my name is Rachel Bromberg, and I'm the co-founder of the Reach Out Response Network. I'm going to talk a little bit about our organization and the work that we're doing with the City of Toronto to support them in developing a new alternative non-police crisis response service. I'm also going to talk about some of the research that our network has done and some of the work we've been doing internationally with cities across Canada and the US who are building similar services in their communities. So first, I'll explain a little bit about what the Reach Out Response Network is. So we are an advocacy-focused nonprofit, like I said, working with the City of Toronto to develop a framework for new crisis response service. That's obviously a picture of me and my colleague Asante, who is our other co-founder of our network. He is really that tall and I am really that short. What our organization does is advocacy, research, resource sharing, community engagement. And we're also the anchor agency for the International Crisis Response Association, which is a service providers network connecting folks across Canada and the US who are building or leading non-police crisis response services in our communities. So I'll talk a little bit about that in a little bit. Oh, actually here, this slide. So our international network represents a whole bunch of cities across Canada and the United States. And there are a lot of cities that already have what we call hybrid style services. So those are services that are non-police, so they're not co-responder services. They're not services that pair a police officer with a nurse or a police officer with a social worker. They're services that are just made up of mental health workers, peer workers, sometimes EMTs, sometimes other medical staff. But they're services that are integrated into the city services, often through the 911 system. So unlike just a completely community-based service like the Gerstein Centre, which Susan is going to talk about a little bit later. So there are a bunch of cities across Canada and the US that already have these kinds of services. So like Edmonton, Olympia, Denver, San Francisco, Rochester, Portland. And then a lot of cities, especially a lot of big cities in Canada and the US, are currently working on building similar teams that are going to launch either this year or next year. A lot of this stuff is very new. So when I started doing this research 2 years ago, almost 3 years ago now, in late 2018, there was only one team that really existed that was a hybrid style team that was made up of civilian workers, but was integrated into 911. And that team was Cahoots, which some of you have probably heard of because it's been getting a lot of media attention over the past year or so. So Cahoots is a service in, like I said, in Eugene, Oregon, that has been operating for 32 years, since 1989. They have EMTs and crisis workers who can go out and respond to mental health crisis calls related to the homeless population. They do some other things as well. They respond to calls related to substance use. They do death notifications, basically any kind of situation where some kind of fast response is needed, but police are not needed. And in the Eugene Springfield area, they responded to about 17% of all 911 calls in, I think it's 2019 that this data comes from. So they take on a very large volume of calls, and they're directly dispatched via the 911 system. So if someone calls 911 in Eugene, Oregon, and they're like, oh, I have a family member who's thinking about suicide, or who's struggling, or who there's a homeless person who is on my property, instead of sending out police, like in most localities, the 911 dispatchers would send out Cahoots to go respond to those calls. And they've been working really effectively for a really long time. And most of these other cities like Olympia, Denver, San Francisco, are sort of trying to build off the Cahoots model and expand it or scale it or adapt it to the needs of their local population. So international crisis response models. So most of the teams that our network is particularly interested in are first responder teams. So those are teams that go out directly from a 911 call rather than a secondary responder team, which is, I think, a lot more common, where you would have like the police officers who go out as primary responders to these kinds of calls. And then if they get on the scene and they're like, oh, this seems like it might have a mental health component, then they can call in the mental health team. A lot of cities have that kind of program, or they have a co-responder program like Toronto has, called our mobile crisis intervention teams, where you have a police officer paired with a mental health nurse. But what we're really interested in is first responder, civilian only teams. And again, there are a few of those already operational and a lot more that are going to be operational soon. A lot of these teams that we're particularly interested in are integrated into 911. We think from the research that we've seen that that's really important in being able to effectively divert calls away from police. If your goal is to get people who aren't police, people who have expertise in mental health crisis or in responding to mental health crisis or responding to homeless populations or responding to substance use, if you want to get those folks responding to the calls that right now are going to police, 911 integration is important, because what we know is that people are trained from childhood that 911 is the number to call when there's a crisis, when there's an emergency, and when people are in crisis, that's often the only thing that they remember. Looking up another 10-digit number, even assuming they know the resource exists, which often people don't, is a challenge. And what we also know about 911 calls is that 86% or 84% of 911 calls related to a mental health crisis are not actually made by the person in crisis themselves. They're actually about 30% are made by family members or friends, about 30% are made by service providers, actually, and about 25% are just made by bystanders who see something going on. They don't know the person, but they're like, yeah, this seems like a 911 situation. So then they just call. And when we know about, I've worked at crisis lines for a number of years, And what I know just anecdotally from that, and from the research on that also, is that the majority of the time people who are calling crisis lines or other numbers it's either the person in crisis themselves who's calling, or sometimes maybe 10, maybe 20 at the most percent of the time, it's a family member or friend who's calling. But the majority of the time, I've never had a call on a crisis line from a service provider. I've never had a call on a crisis line from a bystander who's just witnessing something going down. So it's really important that if those people are going to continue to call 911, that there's a way to make sure that those calls, rather than going to police, get diverted at the source and sent somewhere else. But the other thing that we've seen is that having multiple access points can be really beneficial. So like some people, just are never going to call 911. They're not comfortable with 911. 911 is really strongly associated with police. People are worried about getting police response. So having a service that's integrated into 211, or a service with its own direct number for people who know the number and want to call it, that can be really beneficial. So there are some teams that have only 911 integration, but a lot of the newer teams are sort of experimenting with multiple access points, including its own direct number. And that's something that Toronto is going to be doing when our pilots launch. We're hoping to have 911 integration, but also 211 integration, and also a direct number. I'll talk a little bit about that later. So there are different staffing models for these different crisis teams. Some teams use peer workers, some teams use mental health clinicians, some teams use EMTs or nurses. The use of peer workers, there are a few teams that are already operational that have peer workers. So New York City has a program called LEAD that's run out of one of their big hospitals. That pairs a peer worker and a clinician. San Francisco has a team of 3 people, one of whom is a clinician, one of whom is a peer, and one of whom is an EMT, and they all work together. Baltimore and Denver are also going to be integrating peers into their teams. And that's something that, we have really strongly advocated in Toronto as well, that, peer workers can be really, really beneficial to have on these teams. But it's also obviously important that where peers are being employed, especially alongside clinicians or other workers, that there's equity, particularly pay equity. If you're doing the same job, going out responding to the same calls, making sure that peers are compensated appropriately for that, and that they're treated with respect in the environments that they're working in. Another thing that is different between different cities. So some cities run these kinds of programs centrally through either the fire department or through a new city department. So Albuquerque does this, San Francisco does this, Portland, Oregon does this. There are other cities that partner with community agencies to operate the service. So it's a partnership between, like, for example, in Eugene, Oregon, it's a partnership between the Whitebird Clinic, which is a community health clinic, and the city of Eugene. So it's the agency that's the service provider. And that's going to be the case in Toronto too, where we're going to be partnering with different agencies in each of the catchment areas for the pilots that will operate the program, rather than the staff being city employees. There isn't really any data yet about whether one model what might be better than the other. It seems, for the cities that have tried either of them, it seems to be working well for them, but we're hoping to do some research on that in the future to see whether that makes any difference. There are also different ways of funding these programs. So in Toronto, we have, I think, $8.7 million that are allocated from the city budget over 3 years for our pilots. And that is the case in a lot of cities where there will be money that comes from the city or the state. Sometimes these things get funded from the police budget. So Eugene, Oregon, for example, their team is a line item in the police budget. Sometimes they're a line item in the healthcare budget. Some cities have done it in an interesting way where they've instituted a new, very small tax to fund the teams. So like Olympia, Washington, for example, instituted a 0.1% sales tax that completely funds their teams 24/7. So there are different models. Like sometimes this kind of new crisis team gets talked about as like a defund the police thing, and it can be, but that's not the only way to fund these kinds of things. And this kind of program can absolutely be built and run without doing any kind of police defunding. Principles of care. So that's something that lots of the teams have focused on in terms of making sure that their services are non-coercive, client-centered, and that they actually have adequate time to respond to a crisis. Often these crises are not over in like 10 or 15 or 20 minutes. Sometimes you can be spending like half a day or even a whole day with someone trying to help them get their needs met, make sure they have a safe place to stay, calm them down. So that's something that's really important. One final innovation internationally is a lot of cities are now starting to embed crisis workers into the 911 communications center. Toronto's going to be doing a pilot that starts, I think, over the next couple of months of this. York Region already has one. And I think the OPP either have one or are going to have one soon also, where you have a crisis worker who can, if there's a call that comes in and the initial call taker is like, this seems like a mental health call, particularly a lower acuity mental health call, they can transfer it to the crisis worker who can try to resolve it over the phone. And what we see from the data with that kind of service is that a lot of these calls can be resolved over the phone without needing to dispatch a team. Often people just need resources or they need support, and that call can be dealt with in that moment. So one of the things that our network did is we connected some research into the safety of crisis workers on civilian-led teams, because it's a question that we get a lot of, like, aren't we putting civilian staff at risk if they are attending calls with, people experiencing mental health crisis and police aren't there? That's a comment we get and a question we get constantly. So we did some research. The research is a little out of date now just because we did it in November, and a lot of teams have actually launched or scaled up their operations between November and now. But what we found from the data at the time, from looking at 8 different teams that were operational at that time, we found that no team had ever experienced a serious injury or death of a staff member, client, or third party. Including, Cahoots, which took, 24,000 calls last year and has been taking very high volumes of calls since 1989. They've never had a death or serious injury ever. What we found was minor injuries like, a team's car getting rear-ended on the way to a call, or a client spitting at a staff member, that occurred in about 1 in 26,000 calls. So super, super, super rare. And even of those, a lot of those injuries were not related to clients. They were related to like our car getting hit, or someone tripping and falling, or someone's hand getting stuck in a door, stuff like that. Typical workplace injuries, not fun, but not coming from like, oh, our clients are super dangerous. That perception really comes from stigma. It's not something that is found in any of the data from any of these teams. And what we also know from the data, from 911 call data from Ontario, approximately 89% of mental health calls that police currently respond to don't involve any type of weapon or any harmful behavior towards others. So, that's your low-hanging fruit to immediately divert. These calls could be really easily responded to by a civilian-led team. But we see in other cities, like even Eugene, Oregon, my favorite place, which I've never been to, but my favorite place in my head, is that, police continue to be dispatched where there are substantial safety risks. Like sometimes people ask us questions like, well, how would your team respond to the Danforth shooting or stuff like that? And we're just like, no, the team wouldn't respond to that. That's a situation where there's lots of violence happening. That's a situation that police would continue responding to. So our recommendations. So our network conducted 18 virtual town halls, 2 large surveys, and about 150 key stakeholder interviews in the summer of 2020. We developed a report outlining what folks would like to see in the new service, available on our website. You can go to that web address if you want to read it. It's long. We also have a summary version of that report. The highlights of what people wanted to see in the new service. So folks didn't want a co-responder team. They didn't want police responding to these crises. a lot of folks talked about wanting peer workers or people with lived experience working on the teams. They talked about wanting multiple ways to access the service, including 911, but also, like I said earlier, some folks don't feel comfortable with 911. So they really said, having as many different options as possible is important. Folks talked about the importance of having rapid response times rather than having to wait 2 or 3 or 4 hours. When someone is in crisis, they can't always wait that long. Trauma-informed care, culturally competent care, harm reduction. A lot of people talked about having adequate time to de-escalate a crisis so that folks don't feel rushed. That was something that folks talked about a lot about current services or the MCIT, not through any fault of the current services, but just that there's very high call volume and not necessarily enough staff to actually respond to all of the crises that need to be responded to or to give them the time that they need. Folks also talked about the importance of providing support to families rather than just the identified client. So making sure that families are also de-escalated and connected with resources. They talked about public education component, making sure that folks know that these new teams exist and also what they do to sort of demystify and destigmatize. And they talked about the importance of relationship building and outreach to vulnerable populations to build trust with the service. So what's next? So in Toronto, there are going to be pilots that launch in 4 different catchment areas that will be starting up in early 2022, including an Indigenous-led pilot by and for Indigenous communities. Our city is using the community agency partnership models. So there's going to be an RFP process. I believe it's beginning this month for community agencies in the 4 different catchment areas, including the Indigenous-led pilot, to apply to potentially operate the service. More information about that, if folks are interested, can be found on the city's website. Dispatch protocols are going to be developed for 911 integration, but also 211 integration, and hopefully also a separate number. Our network is going to continue supporting the city with implementation rollout, resource sharing, connecting and facilitating their connection with other cities. We are not going to be the service provider. We don't have the capacity to be the service provider. And there are lots of other agencies in Toronto that do have the capacity that will be amazing providers of this kind of service. So our job is really just to continue sharing the information that we have and facilitating connections. And through the International Crisis Response Association, we're going to continue supporting other cities and developing similar services across Canada and the US, and sort of talking about everything that we've learned about hybrid style models. Okay, that's it. This is all of our contact information if you want to contact me or Asante or learn more about our work or read our report. That's all.
Well, that's, I guess I'll come over to me now, Rachel. Thank you very much. And what a great way of grounding the work today in that. I just want to say I'm Susan Davis, and I'm the Executive Director at Gerstein Crisis Centre. And I really thank everybody for attending today and for your interest in this subject. And I'm going to speak about Gerstein Crisis Centre specifically in our services that we provide as an example of how a community organization can provide a community-based crisis response that stands completely separate from hospital and police, but work collaboratively with. And Gerstein Crisis Centre has been operating for over 30 years, actually 32 years, just like Cahoots came around the same year, so probably came out of a similar movement. And that's what I'm going to share with you today. So I'm going to pull up my screen and see where we're at here. Oh, hold on just a sec. No. Sorry about that. Hang on one second. There it is. Okay. Great. So, is everybody seeing it at this point? Have I managed to share? I hope so. So as I said, I'm going to talk to you about Gerstein Crisis Centre. We're located in downtown Toronto and have been operating for over 30 years, providing community-based non-police crisis response. And I'm going to start off with our mission, vision, and values, and largely really thinking about it in the context of values. And I know Rachel touched on this as well, but it's a really key feature in what your response is going to be, is that it is really driven by the values and commitment to the community. And so you'll see that we are committed to being in our mission to an accessible source of support and recovery for individuals experiencing mental health substance use crisis, to work collaboratively to provide improved, timely, and equitable access to services, and be guided by the voices of people with lived experience, promote wellness, recovery, psychiatric survivor networks, and community initiatives and networks. So I think that's sort of the core to where we came to be. Gerstein Crisis Centre, way back in 1989, came together following 7 years of work with a broad range of people in the community. And we really still believe strongly in that model of community development as an important feature to how a crisis service responds in any particular district. So it may really look different in Toronto than it does maybe in London or somewhere else, because it needs to be really based within the right context for that community. The values being respect, autonomy, dignity, diversity, social justice, equity, collaboration, and accountability are at the core of all we do, and valuing the whole person and acknowledge and respect their needs and wishes for recovery. So really putting that client voice at the core of everything as well. And aside from really coming from a very values-based approach, we also would describe our approach as community-based and non-medical, trauma-informed, harm reduction approach to crisis that respects individuals' ability to define their own identities, experiences, and goals. And just to give you a little bit of background on staff, the staff at the center are all highly skilled and experienced community crisis workers. Typically, people have well over 5 years of experience before coming to Gerstein Centre to work on the crisis team. And they come with a broad range of experience and education. And many folks are including lived experience as part of that. And all the staff are trained in crisis intervention, suicide intervention, harm reduction, and work from a trauma-informed perspective. And like, Rachel was mentioning, really treated people with lived experience are paid at the same rate as a regular crisis worker, all the crisis workers the same, and really keeping that, understanding the power imbalances between providers and between service users and providers, and working to try and reduce some of those power imbalances can go a long way in terms of engagement and also in terms of de-escalation capacity. So I'm going to just quickly move into some of the services that we offer. We have a crisis line that operates on a 24-hour basis, and we've got some numbers at the end of this presentation. I think last year we answered over 30,000 phone calls. And many of the calls will resolve over the phone, but that's not the only, we really do believe that having multiple ways in which to respond to crisis is really important. So while many do resolve over the phone, we also have a mobile team that can go out and see people in the community. And we can meet them in a variety of locations. They may be at an organization that's somewhere in the community, like a drop-in center or a community health center, that kind of thing. Or emergency room, and wanting something other than what's happening there. But oftentimes we're also meeting people, in a cafe or in a park or that kind of thing as well, because we see a lot of people in Toronto who are also living with homelessness or, underhoused in many ways. Along with our mobile team, we also have crisis beds, and we have 10 beds located in one of our locations where we have a short stay of about 3 to 5 days, and I'll get into that more deeply. And then we have about 14 beds. Some of them are designated as mental health and justice, and some are for homelessness and mental health crisis. Along with those 3 responses, we also have recovery and training activities that people can get involved in. And also for people who actually come through the crisis service can get actively involved in, both from participants as well as in terms of the provision of those services. We have a wide range of training and education that we provide to the community. We do a lot of work to make it accessible to many communities, and also adapting it to groups that that would like it in other languages, or to have a cultural bent that would make more sense for their particular community. And then ultimately, community collaboration is really at the core of everything that we do. We work with a broad range of partners, and really that is what gives life and legs to the work that we do, and a really important component. And talk about our approach a little bit. You know, as I just started telling you about the collaboration being a really important piece, it is with our other colleagues and other parts of our system, but it's also really important within the actual work that we're doing direct with the person in crisis or the family member, or you know, other service providers who may be having difficulty helping to support somebody within their services. And really making sure that we are coming up with collaborative solutions with the individual, their families, and their resources, because that's really what's going to make whatever it is we come up with as a possibility for next steps be much more likely to be able to be followed through on. We really want to come at this situation with empathy. We're not there to diagnose or to judge or to do any of that. Really, the idea is to really come from understanding where the person's perspective is, and stay out of judgment, really acknowledge some of the emotions that are involved. And I think, you know, Rachel talked about time spent with people, and oftentimes in our system when people are accessing, there isn't that time for that emotional content to really be able to be heard. And yet it's so incredibly important to a crisis intervention that aspect of what's going on for the person can be given the time and examination it needs to be able to move on to next steps. And then, of course, communicating all that back to make sure that we've got the right understanding, and that the person really sees that they have been heard, which is such a core piece, is listening to what someone is going through. And also, you know, we talk about collaboration a couple times here, but problem solving is really key as well. You know, believing people are the experts in their own lives. Their problems didn't start when they came in contact with the crisis team. They've probably tried a lot of things before they've even come to us. And, you know, this may not be the first time that someone's experienced a crisis. They've really gained knowledge and skill over their lifetime, and are the experts in their own lives in problem solving. So really, you know, keeping that as a collaboration as we go forward as well. Of course, we want to be strengths-based, understanding that, you know, belief that people have what they need, understanding people to be resilient, while that may be compromised in the minute of the crisis, it's still there within them, and really pulling on those strengths, both internal and external, that people have to really be able to manage and build on their capacity to manage crisis moving forward. And, you know, we talk about dignity. Of course, it's hard to talk about dignity without respect, but really coming at this as that we all have equal worth and value. And it really is the path to build relationships and to build rapport, to be able to provide the kind of support we want to during a crisis. This is the definition of crisis that we work with. A crisis occurs when an individual experiences a change which makes them feel both uncomfortable and like they're unable to cope in their usual way. And a lot of times when we use this definition, it's a bit more interactive with our audience to really see how people react to this, because for a lot of folks, this isn't what they think of. They think they'd like to see something a lot more charged, or they think about particular situations that really warrant a crisis. But we really, you know, believe in the person being able to define their crisis for themselves. And sometimes it's not something big, sometimes it's something small. But really all these factors need to be at place where somebody's experienced a change. It could be perceived or it can be real in terms of something that's actually happening. And they might not feel like they're able to cope in their usual way, but just a change and unable to cope sometimes people can still manage that. It's when it's really uncomfortable and it can't exist like that on an ongoing basis, where it needs to sometimes have something more at play in terms of getting the additional supports to get through the crisis is really important at that point. So this is the definition that we work with. It's not clinical, it's purposely not clinical in a lot of ways, but it really does serve us well to be able to include a broad range of issues that people may face that lead them to the point of crisis. Just to give you a sense of how someone might flow through and the different components, you know, we have a crisis line. Obviously, majority, like Rachel said on that call, in the initial call in, are coming from people themselves who are in crisis. We really feel strongly that the system needs to have this kind of place, because when people feel that they have a place that they can call that is safe and that they can speak about their own issues and define that for themselves, they're far more likely to call, number one, and they're probably more likely to call early on in their crisis. And the benefit to that is that the earlier on in the crisis, before things escalate, there are more options and available to people. And if we can get in early, we want to have some prevention capacity, then that really can make a big difference in terms of what the person's experience is going to be through their crisis, and get to solutions quicker as opposed to later. I think we all know that our system right now really requires people get to really dire straits before there's a response, and we need to move away from that and maintain access in such ways that we can get to people when they think they need it, and when it matters to them. We also have referrals from hospitals and police and shelters and all sorts of other organizations in the community that call us, as well as family and friends and neighbors that also come into our crisis line. I'll show you later, we also have a referral line specifically for other service providers that we can take calls in from as well. So this is also really important that we're able to support our system overall to be able to provide non-police and non-coercive crisis response to people on an ongoing basis, and that they can access as well on a regular at time where they need it. I'm just going to go through the slides here a little bit, because I think it sort of highlights those one by one, and I've already gone through that one, so I'll pass this on to the next section. The telephone line, as I said to you, we received well over 30, I have the number at the end, well over 30,000 calls last year. As I mentioned to you, a lot of those calls do resolve over the phone. We offer short-term crisis follow-up and support post a crisis call, as well as from some of our other services that we provide. And this is a really important feature for a lot of people. And it has been extremely important during COVID, where people are feeling extremely isolated and where other services have been less available, and you know, face-to-face has not been possible. So the crisis line is a huge tool in terms of responding, and where the bulk of our interventions will occur. We've got a mobile team, as I mentioned to you earlier, and that team goes out into the community. We're really big fans of that being a pretty non-intrusive look to it. We don't have big signs on the side. The staff aren't wearing T-shirts that say "crisis team." We're trying to go out somewhat in a way that doesn't scream "crisis team has arrived," and where people don't feel the stigma of with their neighbors or with other people around them in that way. So really, it should be a pretty low-key kind of response, with regular people coming out to help where possible. We have, I don't know what happened there. Oh, I guess I'll go back. I'll just do the mobile crisis component, which I mentioned she has already gone out. And through that, a lot of times the mobile team will go out and the person may stay in place in the community, post having time with two people. The benefit of the mobile team going out is it's two people who come out, spend absolutely undivided attention on what's going on, no other competing needs at the time. The individual is at the core there. And it goes a long way to really helping somebody de-escalate, get calm, be able to start thinking about coping again. And sometimes a plan can be just developed on the spot, and the person stays at home or in place and carries on. But other things may happen at that juncture as well. We have short-term crisis beds available, and that may be on offer at that point. And then if a situation is a little more extreme, in terms of requiring a more of a health response, but the person may need support in accessing that, we will connect to other services or to a hospital or perhaps primary care in a different way in the community. And that may be part of the mobile visit too, is helping somebody make that connection. And then finally, connections and support. We have short-term crisis follow-up and support. We reconnect people to existing services they may have become disconnected with or forgot was part of their crisis plan or arsenal of services that might work and help them during a crisis. Provide new referrals to supports that could be of benefit. And then also hopefully provide access to wellness and recovery programs on an ongoing basis. We have two main ways in which we do that, where we take people direct from crisis. They don't need to be in a situation where they're housed or any of that. They can really join our groups immediately, be part of a RAP, a Wellness Recovery Action Planning group, which I say, of course, has been adapted for different communities as well and languages, but also to a group we have that's called FRESH, which is Finding Recovery Through Exercise, Skills, and Hope, which gets people connecting and out and moving and is completely peer-led and people can access, post that crisis intervention. So these are all potential outcomes that they may go through. This is the catchment area that we are currently working within in Toronto. So we go out to Jane Street, to Victoria Park, north up, to the northern part of the city, Eglinton, with that other little loop up and down to the lake. While this is very much our catchment area for mobile visits, it isn't as much for the telephone. They call from all over the place. And a lot of times too, because we do not have the infrastructure for community crisis response built strongly enough across our entire city, people will come within this catchment to meet with us as well. It's a picture of our house on Charles Street, where we have our 10 beds, and just to show it to you, it's meant to be kind of residential and home-like. It's got the house, we often joke as crisis workers, the house does 90% of our work. It's a very calming, home-like, respectful, dignified environment that people really feel they can come to and get some peace and help them work through. This is our 24-hour crisis line, which I've already spoken to. That's the number. And then this is our referral line so that other services are able to contact us. Unfortunately, the crisis line, well, fortunately and unfortunately, is very busy. It can be difficult to get through. It says that we have like a 6-minute average wait time, which is sounds great. It's not so terribly long, but there are times where it's longer than that. So it can be difficult for people. This is what, well, they don't always look like that with their fancy sunglasses, but that's the mobile crisis team. That's what one of the vans that we use to go out to see people, as you can see, pretty unobtrusive in terms of going out in the community. Picture of one of the beds in the Charles Street site, just to sort of see they're all very sun-filled and have basic kinds of things for people to be comfortable during their stay. We also have a concurrent and substance use crisis team, which is really focused on folks who are dealing with more serious substance use issues. We typically get referrals for this from people who have had multiple emergency room visits or involved with our withdrawal management system. The team will both respond to the immediate crisis. There is a crisis that is supported on a 24-hour basis by our crisis line, but during more like 10 till 6 or 11 till 7, the substance use crisis team can also be reached directly, and they'll do immediate crisis as well as short-term crisis management. We also have 6 beds that are located, it's all very animated, whoops, that are located in a withdrawal management site, and that as well as at EVA Satellite, which is 1 bed that's for transitional age youth as well. So there's all aspects of it involved from a substance use perspective. I'll tell you right now, we're working with our local OAT in our city to really try and have a purpose-built 24-hour crisis response for substance that we're hoping this will build into. We also have, through our Gerstein Bloor location, a mental health and justice program that does allow for a 24-hour police access and referral line, and is part of a suite of a number of mental health and justice programs that were funded in partnership in the Toronto area. So this is a picture of our Gerstein Bloor site where we have 9 of those beds. There's actually 14 beds at this location. 5 are for women who are experiencing homelessness and a current crisis as well. These are the number of services that are involved through the network of programs that are part of that mental health and justice network, including housing, mental health, discharge planning, case management, court support, crisis support, which is what we're providing for Toronto, and substance use support as well. And there's another picture of a room, and the stays at Gerstein Bloor are longer. They're up to 30 days. And as we've developed partnerships over the years for those kinds of services where people are facing more complex health issues, whether that be mental health and justice, whether it be substance use and concurrent issues, or we also have a dual diagnosis program in partnership with the Griffin Centre, which is now Luminous in Toronto. We found that when it was more complex, that a longer stay was needed, and so we do have some of our beds offering up to 30-day stays. The Mobile Crisis Intervention and Follow-up Team is a team that is partnered with Unity Health in Toronto. And it's a mobile team and follow-up for up to 30 days. It provides service coordination and collaboration and wellness checks, and it really is additional support to agencies that are out there either on the street level or in the emergency rooms at St. Joseph's and St. Michael's hospitals in Toronto. And really what happens there is either through street outreach or some of the harm reduction sites where they've got somebody who's really struggling with mental health, they can refer to our MCIF project, which will come out and do additional supports for them. And then post an ER visit to St. Michael's or to St. Joseph's in Toronto, our team will pick up and do the follow-up post their ER visit. And what we have found is we've been able to reduce return to emergency room for those folks involved in the MCIF project over 90% of the time, which is immense and been shown to be very valuable. It provides streamlined access, as I already said, to street outreach services, 24-hour drop-in centers, harm reduction services, and St. Mike's and St. Joe's ER. There's a number of partners involved. This is a huge part of how Gerstein, as I mentioned earlier, provides our services, really working in collaboration and partnership with our local local other providers like ourselves. And what we've found is that this really improves access for people to our services, but it also really helps with the ongoing supports that people need and creating pathways to those supports so that post-crisis, there's actually meaningful service provision that can happen. I'm not going to pretend that that is all said and done, all good. I think any of us who work in the system know that we have capacity issues overall, that whether we're a crisis service or whether we're providing anything else, really provide challenges and access issues for people who need them. So we also have a Here to Help team, brand new. It's funded with the city, and it's done with multiple organizations downtown. It's specific to the downtown east area, both Moss Park and Church and Wellesley. And this is a collaboration between local agencies and the city, and really a lot of goals around wellness checks and crisis counseling and access to services, and really ultimately support our community overall, enhancing community connection, empathy, and belonging. This is largely going to be accessed by not people themselves who are looking for services, but people who are concerned about others out there on the streets. And that is a lot of passerbys, as well as some businesses and that kind of thing, or other supports that are out there and looking for additional supports. We have 2 harm reduction workers, 2 crisis intervention workers, a program coordinator, transitional case manager, a youth outreach worker, and 2 part-time peer outreach workers as part of this team. And I talk about it like it's all said and done, but it really is just getting going. And we're going to be launching in the Church Wellesley corridor over the next month or so. These are all the partners that are involved, which has more meaning to Toronto than maybe elsewhere, but just to give you a sense of different organizations involved. We also are part of the focus tables in Toronto, which are situation tables located in police divisions where police can bring people who they feel are at elevated risk and could benefit from access services together to that table, and the community will respond in need. Gerstein Crisis Centre has picked up the largest number of mental health and addiction kinds of issues out of those tables for 14 Division and 51 Division, which are both downtown divisions that see a lot of mental health and addiction issues. And again, here we have seen to really reduce the people's risks moving forward, and we work really collaboratively across a number of agencies that come together at a weekly situation table. We used to come together physically, and now we do it virtually, and I think we're all going to be happy for that to continue. It was a lot of work otherwise, but it really is valuable to have everybody come to the same table. And it's targeted wraparound approach to hopefully the most vulnerable individuals and families, and really for those who are not, who are having a lot of police contact and yet also having a lot of need that hopefully can be addressed in other ways. And we've lowered the risks are lowered 90% of the time based on connection to service and also feedback from people who've been involved. I mentioned earlier about our really having a recovery focus, building a culture of recovery at Gerstein. I've talked a little bit about some of those services that we have available. The picture of some folks out walking, High Park walks are a big thing for these groups, peer-led groups that really provide social connection, community involvement, and bottom line, just physical exercise, which can go a long way in helping with people's mental health. We have support groups that are in person, which I mentioned earlier, and training and education that we provide both to people living with mental health issues as well as to those working with folks living with mental health and substance use needs. And those have all moved online, and we've really been able to shift to that online virtual experience and have done a lot of work across Toronto to make sure communities that have not traditionally had access are getting access now. So just to give you a sense, and I gave 2 years worth just to give you a sense of the number of calls that come into our crisis line. So you can see we're not answering every crisis call that comes into our crisis line, which is really about a capacity issue. And I think if we're going to really move the bar on community-based crisis response as a true option and alternative within our system, we really have to focus on building that infrastructure in such a way that it is an alternative that can really be there. And like Rachel, we've done a lot of work with the people who use our services, understanding what they would want. Their choice would be to have this kind of a response, but it's not always available to them, and they end up trying to access services in other ways to varying degrees of satisfaction. So you'll see we've had a lot more calls to the crisis line this year than we did last year. When I put in answerable calls, as some calls are not willing to wait at all to speak to a crisis worker, and they hang up immediately. So we don't have a chance. If we didn't live answer, we're not getting to them. But then of those, we've answered 42,524 calls this year, which is a big number. And that's just on our crisis line. That doesn't include our substance team or our MCIF or calls that come in through our referral line, just to giving you a sense on that. During COVID, offering house stays has been more challenging for many reasons. We were certainly closed at one part of the beginning of the pandemic, which of course had impact. But also many people don't want to necessarily come for a house stay if they are in their own home, feeling safer getting that support there. And also we have far fewer beds available because we have, while we have a lot of space, sharing washrooms and sharing common space has been an issue. So we have diminished capacity, just to show you that. But at the same time, as we have done that, you can see our follow-up, which we didn't have in place in a formal way in 2019 and 20, has produced over 15,000 calls out to people over the last little while and has been really valuable. So I think I'll stop sharing there, and hopefully we still have a little bit of time left. I know we're at 5 minutes to, but shall we move to questions, Tasha?
Sure, yeah, we have a few minutes here, and people have typed their questions into the Q&A. If anyone else has other questions, please feel free to type them in. And then I think we've also provided contact info for our presenters if you want to connect with somebody directly. So the first question I have here is about the CAHOOTS model, and they want to know if you know what percentage of CAHOOTS calls result in completion where they don't need to call in the police.
Yeah, so fewer than 1% of calls actually require response from police after CAHOOTS has been dispatched. I think the number is 0.5% or close to 0.5%. It's like 300 out of the 24,000 from last year. And most of those were not related to like an offense being committed or criminal justice related. And most of those weren't related to safety issues. They were more about mental health act apprehensions needing to be made, or their equivalent of mental health act apprehensions. If they were talking to someone, they were like, okay, well, this person really isn't willing to accept any kind of support, but we've judged that they're at imminent risk of harm and we have a duty to report. So that was the majority of those calls. But even so, 99.5% able to be resolved without any police intervention.
Great. And so there's another question here. I'm not sure exactly who it's for, but the question is, how are you going to approach the lack of trust in 911 when it comes to mental health crisis and many other reasons?
Yeah, so absolutely making sure that there are multiple access points that aren't routed through 911 is really important. And that's where, I mean, services like the Gerstein Centre, for example, that are completely disconnected. If someone knows that they want help, it's really good for them to have a completely separate place for them to call.
Yeah, I mean, I agree with that, and I think too that also is a very much of a values question, and how the organization or how the response frames the work that they do deeply within what are the community needs, as well as the values that would have meaning for those communities. And while I think we talk about we need really distinct responses, but we also know we have to work together, and that there can be real value in that. So while a call may come into 911, being able to divert it entirely out of 911 and into a community-based crisis response really allows that individual to get access to a service they may not have known about before, or not had made available to them before. So I think while we need to work in collaboration, we also need to make sure we're providing those kinds of distinct responses and acknowledge people's experiences of what those responses have meant to them in the past. We heard a lot about that from people over the last year. I also just want to quickly say, of the 42,000 calls we had last year, I did a check to see how many resulted in a call for greater services, and I think we had 25 out of 42,000. So very small numbers.
Great. Lots of questions here. So another one, what are the strategies you would recommend to prevent services from becoming another form of coercion different from police? They say mental health support should never be coercive, but mental health laws in the US are not consistent with that approach.
Well, that's true, and I think it also comes down to how your governance of your organization is as well. And I think how vigilantly sensitized you stay to the needs of the individuals that you're serving. Gerstein Centre, we have at least 30% of our board who are people with lived experience, and I'd say that's at least. We often have more than that, and we have one of our chair or vice chair or co-chairs, or however you want to put it, is always somebody with lived experience, and we have people with lived experience involved throughout the organization, and also trying to make sure that the people who are working at your organization don't necessarily represent but reflect the community that you're serving, that you really have that lived experience at all levels within your organization, so that you can stay vigilantly sensitized to the people you're serving, that you don't fall into working solely from a clinical mindset, but thinking of mental health in the broadest of terms, and recognizing the many, many impacts that people experience, including social justice and equity issues and racism and the trauma that is associated with that, and having that embedded in the values of how you provide those services.
Great, thank you. And maybe we can just do one more question here quickly. I know we're right at 1 o'clock. There's a question here. Can you describe the type of staff training involved to prepare staff to manage the crisis calls or in-person intervention?
Do you want me to take that, Rachel? Or I know you've done a little bit of work in that area, but so the way it works where we are is that we are looking for people who have been working within community mental health, and it can be in a variety of settings, some from hospitals, some from community, others, within drop-in centers, that kind of thing, who've been working in the field for at least 5 years prior to becoming a crisis worker, so that they really are understanding about the experiences of people accessing services, and also in the provision of services to folks living with mental health and substance use needs. And then, then there are some, required training that is needed, and of course, crisis intervention and de-escalation and suicide intervention training, along with, overdose prevention training and first aid and CPR, these kinds of things that will matter. So there's a variety of core trainings that need to be part of it. Having said that, it also is really challenging just to move. Even if you were a phenomenal case manager working out of a drop-in center somewhere, just moving to the crisis line isn't just as easy as that. It takes a little bit more training on that. We buddy people up with existing crisis workers to really help them start to learn those skills that are needed specifically in responding to those crisis calls.
Great. Well, I think that might be all the time that we have. I wish we had a bit more time, but again, I think, we have the contact information if anyone wants to connect with you directly and ask any questions. And as I said, we'll be sharing the presentation materials as well as the recording to all of the attendees. So look out for an email coming within the next day or so with all of that information, as well as an evaluation survey. So I wanted to thank you so much, Rachel and Susan, for joining us today. That was a really wonderful presentation. So great to hear both of your perspectives and experience. And thank you so much to everyone for joining us today for this workshop. So thanks again, and have a great afternoon, everyone.
Bye, everybody. Thank you.
Bye.